This drawing shows the structures relevant to this procedure. The anterior abdomen is shown with the umbilicus marked in blue for reference. The area between the inferior costal margin, shown here, and the anterior superior iliac spine contains the T8 through L1 dermatomes. The intercostal and subcostal nerves run from lateral to medial across the front of the abdomen, all within the same fascial plane, and these are shown in yellow here. The dermatomes affected by the tap block are highlighted in brown, T10 through L1. This block results in cutaneous and peritoneal anesthesia of the lower hemiabdomen. The tap block has been shown to be effective in controlling pain after hernia surgeries. It has the potential to be useful in facilitating hernia reduction in patients who are at high risk for using high-dose opioid pain medication or for procedural sedation for the reduction of large hernias. Shown here is a large incisional hernia just left of the midline that could be amenable to a left-sided tap block. The tap block could also be useful for abdominal wall pathology, like the abdominal wall abscess shown here. The abscess is confined to the wall, as shown in the CT image on the right. A tap block could facilitate incision and drainage procedure in this patient. The block has also been shown to be useful for pain management in acute appendicitis. To identify the anatomic landmarks for the tap block, place the probe in the transverse orientation on the abdomen, midway between the lower costal margin and the iliac crest. The probe should be lateral to the rectus muscles, roughly at the level of the mid-axillary line. You can make small adjustments to the angle of the probe to make the abdominal wall muscle layers distinct. You will see the three muscle layers of the abdominal wall with fascial planes separating them. From superficial to deep, you will first see the subcutaneous fat, shown as sub-Q here. Then the external oblique, internal oblique, and transverse abdominis muscle layers from superficial to deep. The fascial plane, depicted as this yellow line here that overlies the transverse abdominis muscle, is the target for the block. Be sure to identify the plane of the peritoneal layer, and visualization of this will prevent you from entering the peritoneal space while performing this block. This is a video clip of the scan being performed, showing all the anatomy. In order, you see the subcutaneous layer here, the external oblique and the internal oblique muscle layers, and finally we see the deepest muscle layer, which is the transverse abdominis, and finally the most deep layer is the peritoneal layer. The target fascial plane for the block is the fascial plane just overlying the transverse abdominis muscle. Once the anatomy is identified, you can set up to perform the block. Also make sure that during your anatomic scan, you are looking for blood vessels that could lie in the trajectory of your needle path. There are a few different approaches to inserting the needle that are described in the anesthesia literature. Probably the most straightforward approach is the medial approach, which is shown here. The needle is inserted near the medial edge of the probe and advanced using an in-plane technique. The needle is slowly advanced and is followed in plane. The goal is to place the tip of the needle just superficial to the transverse abdominis muscle layer. Once this is achieved, The injection of anesthetic should result in spreading of the fascial plane, and you'll see separation of the transversus abdominis and internal oblique muscle layers. In this plane block, a large volume is needed of anesthetic to spread along the fascial plane and block multiple dermatomes. 30 mL of anesthetic is recommended. Thank you very much for your attention and for your interest in performing nerve block procedures that can greatly benefit our patients.